Okay, hi everyone that we're letting in. Just to let you know, we're going to keep your audio and cameras off and muted just so that we are focusing on the doctor's presentations. We can go ahead and get started. I just want to thank everyone for joining us for this vaccine program. I want to thank all of the doctors, Dr. Agarwal, Dr. Alexander, Dr. File, and Dr. Agarwal's helper, Janaki Nair. Let me talk a little bit about how the program is going to go. We're going to have a little series of presentations from each of the doctors. And then at the very end is when we will have the Q&A session with the questions that were sent to us ahead of time. So if we want to go ahead and get started, Dr. Alexander is going to give us the first presentation on vaccine and immunology basics.
Okay, thank you, Alex. And let me share this screen and hopefully it works. Okay, there we are. All right, well, thank you. And my goal is to just give you a little bit of a background. I am a clinical laboratory director. I'm not a clinician, not a physician. So give you a little bit of background on the vaccines and the immunology, if you will, of COVID. So I'll talk a little bit about the virus and how it infects us, how coronavirus vaccines work, and the laboratory tests that we have available. This is a picture of the virus. You've probably seen this on the news or TV a number of times. And the things I want to point out at this point are, I think I'm screen share, there we go, and are both the spike protein on the outside of the virus, all these little spike, the nucleocapsid protein. This is a protein that's inside the virus particle and actually is bound to the RNA, to the genetic material in the virus. So those are the two proteins that are going to become important when we talk about the vaccines and the disease. So the spike protein is actually how the virus gets inside the cell. The spike protein on the virus binds to a protein on our cells called ACE2, and that allows the virus to actually enter the cell. So what you might be thinking at this point, what we want to do is block that binding. If we can block the binding of the spike protein to the ACE2 protein, we can keep the virus outside the cells and it won't be able to infect and cause disease. So we do that with antibodies, and antibodies are these little Y proteins that you see here. So the goal of the vaccine is to make antibodies to the spike protein, and that will actually allow these antibodies to bind to the virus, bind to the spike protein, and they prevent the spike protein from recognizing this ACE2 molecule on the cell. So that's the whole purpose of the vaccine, to allow us to create antibodies that will bind to this spike protein and prevent the virus from actually getting inside our cells. This is the other purpose of a vaccine. This shows how an immune response actually occurs when we're infected with COVID or really any type of bacteria or virus. After initial exposure, it takes a week or so for us to make a little bit of antibody, and we'll make antibody between 1 and 3 weeks after the infection. But see what happens the second time we see something. We make a whole lot of antibody much quicker. Within a day or two, we can make a whole lot of antibody as opposed to just a little antibody the first time we see a virus. So the purpose of the vaccine is to give us this first response. And then so the second time we see it, we actually get a booster effect and get a whole lot of antibodies. This is one of the reasons why some of the vaccines are 2-shot vaccines. The first shot puts us in this part of the graph. The second shot puts us over here and allows us to make a whole lot more antibody. This is a listing of the vaccines. Dr. File is going to show a similar slide, but the ones that are now out here are the Moderna, the Pfizer, and then the Johnson & Johnson down here. The Moderna and Pfizer are similar. They take little pieces of the genetic part of the virus, the so-called RNA, and then we'll use that to actually inject inside us, and we can make the spike protein from that RNA and then make antibodies to the spike protein. The J&J vaccine actually puts that RNA inside of a different virus called an adenovirus, which will allow the individual to make antibodies against the spike protein, but this adenovirus doesn't cause disease. The other issue you see with this is the storage, and the difficulty when the Pfizer vaccine first came out is a lot of places didn't have ultra cold freezers to keep the vaccine very cold. The Moderna vaccine can be done in a typical freezer that we might have on a refrigerator, but these require, because ultra cold storage, because RNA will fall apart if you look at it the wrong way, or if it's kept too warm. It's very, very labile. So we have to keep it very, very cold. But when we put that RNA inside another viral particle, that virus particle doesn't require ultra cold temperatures to stay stable. So because of that, we can actually have the J&J vaccine stored in a refrigerator. So it's a lot easier to ship, a lot easier to store. This is a complex slide. I'm only showing it for one reason. If you look over here, you see something that says pro-inflammatory cytokines. Cytokines are small molecules that take a message from one cell to another, and they're heavily involved in immunology and inflammation. So the stronger an immune response you make, the more cytokines you actually have. And you may have heard, or if any of you have had the vaccine and you get a second shot or a booster effect, you have an inflammatory response. Fever, aches, pains, and that's due to the production of all of these cytokines. So it's sometimes called a cytokine storm that actually leads to the side effects that you might receive from a vaccine, particularly the second shot of a vaccine. After the vaccine, or if somebody might come down with the disease, we may do a variety of different laboratory tests that we have available for COVID. And you've probably heard about all of these on the news. But the molecular test, or PCR, is really the most sensitive test to diagnose a current infection. However, an infection much quicker than the PCR test, but it's not quite as sensitive. We get a result very quickly, but the result isn't quite as good as we get from the PCR. But following a vaccine, we may want to do an antibody test, and this will actually look for the antibody response to the virus or to the vaccine. And here's where we're going to have a little bit of difficulty with the antibody test, and I'll mention this in the next few slides. This is an actual clinical question that was brought to me from a patient who had 2 doses of the Pfizer vaccine, and 3 weeks after the second dose, she was tested for antibody, and she was negative. There was no antibody detected. So the question that was brought to me is, does she need another shot? And this is a question I might have referred to Dr. File or Dr. Agarwal, but I had a different question for the patient first. And that's because the antibody tests, there are 2 types that are out there. One picks up an antibody to the spike protein. Remember, that's the protein that's in the vaccine, and also that's the protein that actually binds to a cell. And another similar test is an antibody to the receptor binding domain, which is a small portion of the spike protein. But also, I mentioned in the first slide, the nucleocapsid protein. This is the most immunogenic protein, if to use that word. We get a much stronger response from a natural infection to the nucleocapsid protein than we do to the spike protein. But this is not included in the vaccine. So the vaccines only induce the anti-spike protein antibody. So to monitor the vaccine, we want to ensure that the test we use measures the anti-spike protein, not the anti-nucleocapsid protein. And our patient actually had been tested with an anti-nucleocapsid protein test. So we retested her with an anti-spike protein, and she was actually positive. So she did make a good response to the vaccine. But it's just something that we need to be careful of when we do testing after a vaccination. So to sum up my portion of the talk, that our SARS-CoV-2 is the coronavirus that causes COVID-19. Vaccines induce antibodies and T cells. We didn't talk about those, but that's another part of the immune response that fight the virus. We have molecular and antigen tests to diagnose a current infection, and antibody tests to diagnose exposure or to monitor the response to the vaccine. And if we monitor the response to the vaccine, we should use the anti-spike protein assay, not the anti-nucleocapsid protein. So with that, I thank you for your attention, and I will turn this back over to Alex.
Okay, thank you so much, Dr. Alexander. Next up, we are going to have Dr. Agarwal. You said you had a couple of slides before.
Correct, yep. Good evening, yep. Let me share my screen. Okay, can you see that? Is that good? Okay. Good evening. Thank you all for inviting me to speak tonight. And I will be presenting a few slides, but I have Janaki Nair here, who's a 10th grade student at Solon High School and has done a lot of exceptional work with me with epidemiology and with COVID-19. and really has a vast interest in the topic. So I will have her present a majority of the other slides. And so what I wanted to do is give, a brief COVID-19 update. So, where are we a year later in COVID-19? So if you all remember, the first case of the SARS-CoV-2 was diagnosed January 20th, 2020 in the United States. At that time, there were probably a lot more cases, but we just were so limited on testing. Even in our institution, we were very limited on our capability to test. So there were probably more that we just hadn't diagnosed at that time. And back in January, and even probably through March and the end of March, we were really at that point learning more information on transmission of the disease and the clinical illness. A lot of institutions, whether they're hospitals or not, were working on PPE and how do they protect themselves, their employees, and all the shutdowns were happening and everything. So that's kind of where we were over a year ago. Now we actually have a lot more information on the clinical disease. And we know from treating so many patients is that patients with COVID-19 can have a viral response and a host response. And that's sort of how our therapies are geared. We're gearing them towards a viral response and the host response. And I'm going to just hit on that very briefly. If you look at COVID-19, what happens is that when you first get the disease in the first couple of days, you have maybe very mild symptoms. But this is where you have a lot of virus in the body, in the blood. There's a lot of virus that's going on in the beginning. The problem with COVID-19 is as the days go on, you can get into this stage where it gets into the lungs, which is your stage 2, or known as the pulmonary phase or the lung phase. And then what happens is as you get about 10 days or beyond 10 days, you get into this host response where you start to see more of the inflammation. So it's not that you're really dealing with the virus at that time, but you're dealing with how your body is responding to the virus. And so it just goes into this big immune dysregulation where your immune system is it's kind of revved up. And so you're getting this host response. And this is where, some individuals have a lot of problems. And if you look at the different stages, people can be asymptomatic or pre-symptomatic where they have, basically no symptoms. There can be mild illness, moderate illness, severe illness, and critical illness. From a year ago, I have seen so many patients and treated so many patients. I've seen them in all these different phases. And it's hard to predict. Some patients stay in this phase and they get better. Some progress all the way to critical illness. Some will make it will come up to this moderate illness and then get better and be discharged home. Most, about 80%, will recover. But then, as we've lost a lot of people to severe and critical illness. Where we look at our treatment options kind of hit at the two things, the viral response and the host response. So we have antiviral therapy, antibody therapy, which, the point of this lecture is not really to go into specific therapies, but I just wanted to let you know from a clinical aspect, this is kind of where we guide. This is how we choose what kind of medications we can give for patients with COVID. So we try to see where they are in their illness course. And then as they get further on into illness course, we look at the inflammation. This is where we really push the steroids and drugs that are similar to steroids to sort of help that inflammation. But, I think that the focus of this talk is really the community and what we can do. Our best, in my opinion, we need to keep people away from any of these stages. And I know the numbers are coming down, and we still need to really, really concentrate on our preventive measures, which would be, wearing a mask, keeping that distance, washing our hands with soap and water, and obviously the vaccine, which is the newest thing that's been here since December of last year. So that's really where we need to focus. We need to continue to focus on these preventive measures. And with that, I'm going to go ahead and hand it over to Janaki Nair.
Thank you, Dr. Agarwal. Let me share my screen. Okay, are we seeing that? Yes, okay. All right, so hello everyone. My name is Janaki Nair. I'm a 10th grader at Solon High School. Thank you so much for giving me this opportunity. I will be talking to you today about preventative measures for COVID-19. So as of March 2021, close to 115 million people have gotten the coronavirus. That is the same number of people predicted to be pushed into extreme poverty because of the virus. 2.5 million lives have been lost. This is the reality we live in, but it does not have to be so for much longer. As we close in on our goal, it is more important than ever to help public health officials control the virus through preventative measures. So why do we wear masks in the first place? It protects yourself as well as others by interrupting the chain of transmission. This chain describes how an agent, the virus, gets to the susceptible host, you. COVID-19's chain of transmission is through respiratory particles. When we breathe, speak, laugh, cough, or sneeze, we give off aerosol molecules that could harm another person. These molecules enter our body through our nose and mouth, which is why it's so important that we wear masks. So why should you wear a mask if you're not showing any symptoms? Even if you don't realize you're infected because you're not showing symptoms, you could be a carrier, able to pass the disease on to others. This is called asymptomatic infection. Anyone around you could be a carrier, which is why it is important that we adhere to the CDC guidelines. So I know the guidelines changed today. I think Dr. File will be going into that later, but this is what I have. Masks are not a substitute for social distancing, and you should always wear a mask with someone who does not live in your household. You should wear a mask when you're traveling or going to any populated public areas such as movie theaters, recreation centers, etc. Your mask should be worn over your nose and mouth, snugly on both sides, and after you remove your mask, you should wash your hands for 20 seconds under soap and water, or with 60% alcohol hand sanitizer. You are allowed to take off your mask in non-crowded parks with household members. As for social distancing and social gatherings, it's basically the same as masks. You should avoid sick members of your household. Make sure to have 6 feet between non-household members and yourself. You should take special care around high-risk individuals. These could be immunocompromised individuals whose immune systems are already fighting another illness, pregnant women, elderly, or infants. You should avoid restaurants, bars, fitness centers, movie theaters, etc. And you should also avoid poorly ventilated spaces with not much airflow coming in from the outside. And last but not least, the vaccination. So the biggest concern that the public has about the vaccination is whether it is effective and safe. It is scientifically proven to be both of those things. The vaccines that we have currently available under emergency use authorization would be the Pfizer vaccine, the Moderna vaccine, and the newer Johnson & Johnson vaccine. Vaccines help your immune system recognize and fight the coronavirus. There is a period of susceptibility after the vaccine, which means that even after you get your dose, for a couple weeks, you might be susceptible to the coronavirus. And side effects are normal signs that your body is building protection against the disease. Common side effects that we've seen would be mild pain, swelling, possible fever, or chills. Although we are sure of the vaccine's role in preventing serious illness, we are unsure of its role in preventing transmission. This is why we must continue to adhere to preventative measures like wearing masks, washing our hands, social distancing, until our goal is reached. And what is this goal that I keep mentioning? Our goal would be achieving herd immunity, which is when a large part of the population is immune to COVID-19. As you can see in the picture, when no one has immunity, COVID-19 has many opportunities to spread quickly. The more immunity we have in a population, the more a contagious disease is contained. Dr. Fauci, the CDC, and other health officials have said that our herd immunity threshold would be from 70% to 90% of the population for COVID-19. And that is if we continue at our current pace, which is 1.7 million shots administered per day. As you can see in the graph, the blue area is the herd immunity range that I just mentioned, 70% to 90%. The orange line is total immunity, so that's not just immunity due to the vaccine. And we reached that threshold in July. Immunity due to just the vaccine would be predicted to be reached in November. But that does not mean we can slack off on our preventative measures such as masks, social distancing, washing our hands, etc., because between now and July, 100,000 people could die from the virus. This is why it's important to keep up these measures. And with that, thank you. And Dr. Feil, I think we're next.
Well, thanks, Ms. Nair. Janaki, if I may call you by your first name, that was an excellent presentation. I just want to reinforce, actually, that I think the way we're going to get out of this pandemic is two ways that you just mentioned, and that's by masks and by social distancing and by other mitigation practices we're going to have to follow for a while. But the real tool is going to be the vaccine. And so I just want to make a few comments about the vaccines, and then I know that there's concerns about the variants as well. So Shanu, if you'd be so kind as just to advance to the next slide. Dr. Alexander mentioned some of this, so I'm not going to go over the target of the vaccine. He mentioned that it's the spike protein. He mentioned the technology, mRNA versus the adenovirus vector, the doses, as he also mentioned. What I really want to review is the vaccine efficacy. Now, if you look at what the endpoints were for each of these studies or the clinical trials, it was, does the vaccine prevent clinical disease? That means, does somebody get sick? Do they develop symptoms? And you're probably aware in the initial studies, results from both the Moderna and Pfizer was well over 90%, which is truly remarkable. I mean, virtually, we don't have any other vaccines that have that degree of efficacy for the endpoint. I guess the only other one really that I know of that really does this is the HPV, the human papillomavirus vaccine that really prevents cervical cancer in 95+%. I think the new Shingrix or the Zoster vaccine is close to 90% as well. But I mean, most other vaccines, it's probably 60, 70% at best. But I want to point out, if you look at the J&J vaccine, the overall endpoint looks like 66%. So you might say, well, is this not as good as the Moderna and Pfizer? And that you cannot interpret it that way. All of these, as Janaki has said, they're all very effective and safe vaccines, because they were, the J&J vaccine, you'll have to recall, was done at a different time and different geographic areas. For example, many of their recipients in their trial of the J&J were from South Africa. And you may be aware that, and I'm going to talk about this in a second, but there is a more resistant variant in South Africa. But even in South Africa, the rate of efficacy was 64%. So, that's still very good. But what I really want to point out is that if you look at the efficacy in preventing serious disease, by that I mean patients who require or are sick enough, like Shanu said, to come into the hospital, or certainly to prevent death, all three of them do that. All three of them, if you look at once a patient has been fully vaccinated, and the J&J, that's after 28 days, and then the Moderna and Pfizer, it's 14 days after the second dose, there was virtually no recipient that was sick enough to come into the hospital, and certainly nobody that died. So that's very good findings, and I just want to stress that. So that, to me, all three of these are very effective in preventing serious disease. So anybody who gets a chance to receive any of these vaccines should go ahead. Now, Janaki also mentioned this concept about asymptomatic infection and the possibility that this might be involved in transmission. And there's preliminary data from all three of the vaccines, although I only have two of them listed here, but using different techniques. I mean, in the Moderna vaccine, they actually looked at the ability to identify the virus by PCR just before the second dose. And there was a significant reduction in those patients that received the vaccine versus the placebo. In the J&J, they looked at seroconversion, much as what Dr. Alexander mentioned, so that they looked at the antibodies to the nuclear capsid, because that would reflect actual infection. And again, patients that received the vaccine had much less likelihood of having evidence of asymptomatic infection. And then the Pfizer one, it's more indirect, but there is data from Israel where they've been able to inoculate a high percentage of their population that has been shown to be associated with reduced transmission, and that was with the Pfizer vaccine. Now, Janaki also mentioned the side effects, and I just want to comment that these are all expected side effects, but they're all transient. And as she said, I mean, it's very common to have local pain on, or let's put it this way, discomfort at the site of injection. Also, there can be associated fatigue, headache, myalgias, low-grade fever, and even with the Moderna vaccine, there can even be enlargement of the local lymph nodes. So, but these are to be expected. You can ameliorate them after you've received the vaccine if they do occur with agents such as acetaminophen or ibuprofen, and that seems to ameliorate those types of symptoms. And then the last slide I have is just a comment about the variants. So if we could have the next slide, Shanu. I just wanted to, well, actually, I guess I have two slides. Yeah, I forgot about this, because I did put this slide in today, and I think Janaki has mentioned this, that just today, the CDC issued new guidance concerning post-vaccination recommendations. So the point is, after a person has been fully vaccinated, which is 2 weeks after the vaccination, which would be 2 weeks after the second dose if you have one of the 2-dose regimens, now there can be some changes. And I think these are very good sort of news that the vaccines are going to help us get out of this pandemic. It's really sort of a gradual step in the right direction. So what is the change? Well, what is stated now is that if you have a fully vaccinated person, they can gather indoors with other fully vaccinated people without wearing a mask. But I want to caution here, this does not mean you can bring in a large or a moderate sized group, and I'm talking about 20 people who may not even be part of the family group, or who may not even be friends. If you have all kinds of different people, even though they say they've been vaccinated, that's not what they're recommending. What they're recommending is, household contacts, family members, maybe friends, close friends that can come into a person's home, maybe 6, 8, 10 people at the most, and if they've all been vaccinated and they've been more than 2 weeks, then you can congregate without a mask. And I know the question is, well, can grandparents, now visit with their grandchildren? Now, of course, many of the grandchildren wouldn't have been old enough to receive the vaccine, but that's the second point here, that you can have gatherings indoors with unvaccinated people if you've been vaccinated, as long as it's just from one household, unless there's increased risk. So that would answer the question that a grandparent who is fully vaccinated may visit with a grandchild, as long as that grandchild is not at high risk of acquiring the vaccine, or the infection, and with complications, because as we don't know for sure is to what extent the vaccine will prevent asymptomatic infection and possible transmission. And then the third change is that if you've been fully vaccinated and you've been exposed to somebody who has COVID-19, you do not need to quarantine or test as long as you're asymptomatic. Now, if you develop symptoms, then you should test. What has not changed is still the importance of masks in the public area, and then gathering with unvaccinated people if they're from more than one household. And it certainly still is what recommended to avoid medium or large gatherings, even if you've all had the vaccine, at least at this point in time. I think eventually we'll be able to do that, but not quite yet. And we're still learning. If you look at the posting on the CDC website from today, stating that we're still learning about the effect of the variants that I'll mention in my last slide, and then about the effect of the vaccine on asymptomatic infection and transmitted, which we've already mentioned. So now my last slide, we'll talk about some of these variants that you've heard about. And we know that these viruses, RNA viruses, they commonly mutate, and they commonly mutate as they replicate. And these are just random errors in replication that occur. So that the greater there is replication, the greater there's transmission, the greater the chance of mutations and variants. And that's why our message has always been, if we comply with these mitigation behavior and reduce distance, or increase distance or maintain distance between persons, and particularly the mask. The masks are extremely important until we get the herd immunity that Janaki has already mentioned. So that's very important, so we can reduce transmission, therefore reduce the numbers of these replications that occur. So I've got on the top here various variants that are known. And if you look at the first column, this D614G, I just want to comment that this is a variant that right now accounts for about 90% of all the infection in the world. This is different. This is a variant, actually, and it's the most prevalent variant so far in this country and in the world, as I said. But it is different than the original Wuhan strain because it is a variant. Now, fortunately, this particular variant, although there is associated with somewhat higher transmission, it's not associated with any increased severity of disease, and certainly not increased with mortality. And there's no resistance to the vaccine. So that's very important. Now, the next one, this B117, is the one that originated in UK, but is now spreading worldwide, and now represents about 20 to 25% of the strains in the United States, which is a significant increase because 3 weeks ago, it was only 2 or 5%. And it's predicted by the end of this month that it probably will be the predominant strain in this country. It's now actually, the cases that I've got listed here are from a week ago, and now it's well over 3,000 cases that have actually been identified in now 48 states. It definitely is associated with higher transmission and, unfortunately, with increased severity and mortality. However, the good news is there's little resistance of this strain to the vaccine. So the vaccine is going to be effective against this particular variant. And the good news in the United States so far anyway, is that 97% of all these variants, with the exclusion of that first one, that 614G, 97% of the variants are this variant. And so the vaccine should work against it. Now, the next two, the South Africa and the Brazil ones, are the ones we're concerned about, but fortunately, very limited so far that has been transmitted within the United States. And the problem here is that there is some moderate vaccine resistance associated with these two variants. However, having said that, and remember what I said about the experience with the J&J vaccine in the South Africa clinical trial, while it may not have prevented disease as much as we would like, it prevented serious disease requiring patients that have to come into the hospital, and certainly it prevented deaths. So, I mean, that's very important. And that's a similar consequence with that Brazil vaccine. Now, there are a couple that have occurred within this country. There's the California variant and the New York variant, much of which we don't know yet. But we'll have to see as as we gain more information about these. But I thought I would just give a little bit of information about these variants, and particularly the last row about what the impact of these variants has on the efficacy of our vaccines. And as I said, I just want to sort of reinforce that right now, if the predominant variant occurs, which it looks like it is that B117, the vaccine is still going to be very effective. So I will conclude my remarks now, and I'll be happy to participate in the question and answer time.
Okay, thank you so much, Dr. File, and thank you, Dr. Agarwal and Janaki. Those were great presentations. We can get started then on the Q&A. The first question that I'll go ahead and ask, and then I'm gonna sort of tag team with Carrie, who's also in here. You guys might recognize her from the library. So the first question that someone sent is, I take 2 grams a day of a turmeric supplement. Can I still take this when receiving the COVID vaccine? Does anyone see any issues with that?
Well, I can start, and I see no issue with that. I mean, if they're taking it because they have arthritis, I mean, that's fine, but there's virtually no contraindication to any medicine that a patient is taking to this vaccine. Now, there are some issues about how you might delay the vaccine if you've taken one of these monoclonal antibodies, because then we would request that the patient not take the vaccine for 3 months because the monoclonal antibody would interfere with the effect of the vaccine. And we also know if patients are on immunosuppressive therapy, like many patients with arthritis may be on immunosuppressive type therapy, we still recommend that you receive the vaccine, although the studies did not include these types of patients, immunocompromised patients, but we still recommend that they receive it with the understanding that because of immunosuppressive therapy, like high dose steroids, et cetera, there may be a reduced immune response, but nevertheless, we feel it is important to receive the vaccine.
Yeah, I just wanted to add, medications that you're taking on a daily or chronic basis are okay to continue. There have been some, nothing's really been proven, but, we sort of recommend not to take Advil or like a non-steroidal drug or like acetaminophen or something prior to the injection, because people feel like, they just don't want to have the pain. So it's okay to take afterwards, a couple hours afterwards, if you have pain at the site, but we sort of encourage patients not to have it beforehand, just to make sure they get the best immune response. And then the other thing is steroids. Some people are on a short course of steroids because of asthma or because they have like an injectable steroid into a joint. Again, those sort of medications, for something like that, we would recommend waiting on the vaccine for about a week or two, just to make sure the steroids don't blunt your immune response.
That makes sense. So our next question is about the efficacy of the different brands of the vaccine, which we've already talked about quite a bit. So I don't think we need to ask that question the way it's written. The one part of this question, is there a reason to prioritize getting one brand over another? I'm not certain that you can choose when you're signing up for the vaccine. Is that correct?
Well, that's true. And I would say the prioritization is based on what vaccine is available. That should be the priority. So if whatever vaccine is available, go ahead and take that. There's been a lot, as I said during my presentation, people like to compare the vaccine efficacy results of the 94, 95% versus 66%, but you can't do that because there's been no head-to-head trial comparing one versus the other. And as I've already said, it's almost like apples and oranges because the protocols were a little bit different for the clinical trials. They were done at different times. Certainly the J&J, when these variants were becoming occurring, and in different geographical areas. Both Brazil and South Africa recipients were included in that J&J trial. So again, my feeling is that all three are effective, and whichever one you can get, that's the one you should prioritize.
I'm going to ask a corollary to that question for Dr. File. This question has come up to me a couple of times from people who have had the Pfizer vaccine for the first shot, and then it's not available for the second, and they were going to get the Moderna, and then they were asking me, does it really matter? So, Tom, do you have any comment about that, or Shanu?
Well, the CDC has guidance to that because there are going to be some people who don't, might have gotten it at different sites or institutions, and they don't have the record of their first vaccine. And so what the CDC recommends is that the second dose should be the same vaccine as the first. But if you don't know, and if you know the first was an mRNA, which is obviously going to be 90+% of the people that received the vaccine so far, then it's okay to substitute whatever other one of the mRNA vaccines is available rather than not getting the second dose at all.
Okay.
Okay, great. Thank you so much. Did anyone else want to add anything? Okay, we'll go on to the next one. And Dr. File, you touched on this in your presentation on grandparents being around grandchildren when the grandparents have been fully vaccinated. I guess the part of it that people might still be wondering is if they still need to take the same amount of precaution, maybe with their grandkids out in public, that kind of thing. Would you be able to speak to that?
Well, right. And the guidance, and it's just fully available on the CDC website, which is available to everybody. I mean, they still make the comment that even if you've been fully vaccinated, when you're out in public, you need to, do all of the mitigation practices that Janaki has very expertly reviewed. I mean, mainly because, we're still not absolutely sure. I mentioned that there's indirect evidence, but and I really think that the more direct evidence, as we accrue more of that, will show that the vaccines will reduce transmission. But until we get a high percentage of the population vaccinated to whatever this herd immunity is that Janaki's already mentioned, we still need to wear the masks and practice distancing. So yes, when you're out in the public with your family members or with friends, still wear the masks.
Kind of a corollary to that, Alex, do you mind if I interject a quick question?
No, go ahead.
We have many people asking at the library about when they can use meeting rooms and study rooms. Now, we do have study rooms are available to one person at a time, and they have to wear their masks at all times. But with this new guidance, I'm expecting people to ask, well, when can I use a meeting room? As long as I'm vaccinated and my friend's vaccinated, we should be able to meet together, right? Without our masks. I'm expecting those kinds of questions. How would you suggest we respond as an institution to those types of questions? When will it be safe for people to meet in public?
Well, that's a good question, because if you really look at what the intention of the guidance is, when they're talking about individuals who are all fully vaccinated without masks, they're talking about in persons' homes,
right?
Not in the public. So right now, I would not consider that appropriate. I think eventually it will be, and maybe not too much longer. I mean, if you have pods of people who are either family members or they're close friends, or so they're interacting a lot together anyway, then probably we're going to be able to do that in fairly a short time. The problem is if you have a meeting, let's say even of a dozen people, and they're all from different homes or they're different areas, and they're not necessarily close friends or have been not congregating, but that's where there's going to be some risk. Mm-hmm. But still, at least the intention that I interpreted, because I listened to Dr. Rochelle Walensky, who's head of the CDC, at least part of her press conference this morning, at the end of the morning. And she really implied that what they're talking about was, when you have fully vaccinated people in the indoors, you can take off masks, but they're talking about in private or in persons' homes, not in the public.
That was how I interpreted it as well. And that's great to hear, so that we have that testimony to refer to when people ask us, well, if I can gather in someone's home, well, this is not someone's home. As much as the library can feel like it's someone's home, it's not.
I mean, then you also have the other issue of, although this is not a major way of transmission, but you have the other way of environmental transmission. I mean, if somebody was in that room and they were potentially shedding it, did they adequately disinfect the table or the chairs or whatever? Mm-hmm. So you have that other issue in there as well.
Yeah, and I just wanted to add to that. Dr. File and I were having this discussion today at work, and I think we need to wait to see more guidance as how this applies to the general community and libraries and whatnot, because ultimately, I think it is the library's responsibility then if, and how do you know that they were vaccinated? That's not something, because you're kind of violating HIPAA too, by asking somebody their personal health information. So that gets into a tricky situation. So my suggestion is to not change anything. I will tell you from the hospital, on the hospital side, because we have maybe, most of all of our employees are vaccinated, but then there are still, it's not 100% that are vaccinated. And I can't really ask everybody if they are or not. So we have not changed anything on the hospital front.
That is good to know. But we have been getting questions now for several weeks. When will you reopen? When will you reopen the playroom? Things like that. And we are not intending to do anything like that at this time. So the next question is, how long should someone wait after they have been diagnosed with COVID-19 until they can take the vaccine safely? And I believe we talked a little bit about this in the presentation. About the antibodies, but I don't know that we specifically addressed. So if somebody maybe just recently got sick, how long they need to wait?
So if you recently had COVID infection, as long as you're out of your isolation period, so usually for most people in the community, it's 10 days from when your symptoms started. And at that 10-day mark, you can go ahead and schedule your vaccine, with the understanding that you're feeling better, you're on the mend. So you're definitely not getting worse, but you're getting better. You can go ahead and get your vaccine. You don't have to wait 3 months like you do with the monoclonal antibody.
Yeah.
Okay.
Yeah, I might add that if you look at that in the CDC guidance, it will say at a time when we have limited numbers of doses of the vaccine, you may, and it says may, wish to wait and allow others who don't have any immunity to get the vaccine first. Because once you've had natural infection, you are going to have a degree of immunity. And you've heard this threshold that the CDC puts forth of 3 months, but that's sort of a generalized statement. It doesn't mean that you should wait 3 months at all. I still recommend that once a person has had natural infection and as Shanu mentioned, and they're out of the isolation phase and they're feeling better and they've resolved their acute illness, I still recommend to go ahead and get the vaccine. Although, as Dr. Alexander mentioned, you might have somewhat of an increased side effect profile, but still it's only going to be transient. I mean, the ones that we've anecdotally observed, because we've seen several of our healthcare providers who have had COVID and then they've had the vaccine. And in general, they seem to have a little bit a higher rate of maybe fever and myalgias or muscle aches and fatigue or whatever, but still it's transient and it does go away.
Okay, thank you. The next question we did sort of cover in that you said people preparing to get the vaccine should not be taking medication ahead of time in anticipation, right? Like ibuprofen or acetaminophen. Are there any medications that you would recommend once people have the vaccine and are experiencing side effects? While they're currently experiencing them, are there any that would be preferable to take over others? Like, should they reach for Motrin instead of ibuprofen or anything like that?
Well, actually, either. The only thing that I would state that if pregnant women have taken the vaccine, it's recommended that acetaminophen is preferred rather than NSAIDs, but that's just for pregnant women.
From a purely immunologic standpoint, I don't know that this relates clinically. Acetaminophen or Tylenol would be much better than Advil or Aleve because you're not actually blocking the immune response with acetaminophen. However, given the I think as Dr. File mentioned, Dr. Agarwal may mention this also, as long as you're not taking it before you have the shot, it still should be okay. I had a very strong reaction to my second dose. I took Tylenol and was down for a day, but as Dr. File mentioned, for me, I knew that this was only going to last for a day. And so psychologically, I think that helps a lot to know that it is a transient effect.
That kind of goes into my next question, which on our question sheet, we've already addressed this question about the differences between the mRNA and viral vector vaccines. But what I thought I might add to that question is that a group that I'm in that we now meet on Zoom recently was discussing this, and most of the folks in that group are over 60, so they've all gotten their first dose, or some of them have gotten their both doses. And they were saying that older folks don't seem to have as much of a strong reaction to Moderna. Have you seen that in your practice, or is it kind of all across the board?
No, that's definitely been shown in clinical trials and in clinical practice, that if you're over 65, I mean, the incidence of the reactogenic adverse events is less.
That's interesting.
Boy, now you tell me, Tom, I'm 69 and I had, I was down for a day.
Well, I'm saying it's less. I'm not saying it doesn't occur.
Right, yeah.
Okay. So for my friends in the group who are who are about to get their second dose, there's no guarantee they're not going to get side effects if they are over 65.
Correct.
It's just less of a chance. Okay. I know some of them were planning to view this recording, so they'll be interested in hearing that information.
I mean, I guess I would advise people who are going to get their second dose, and if they have some very important function that they have to do on the next day, I would probably do it on a different day or something like that, if you understand what I mean, because they may feel very tired and have muscle aches and headaches, and they may not function as well that day. But other than that, it's going to be transient.
Right.
Yeah, I think that's a great point that Dr. File just made, is that, you know, if you've got a big event, or if you're traveling for some reason, to schedule it in such a way that expect the next 2 days, because I know I had mine on Friday and I definitely made sure I wasn't on call, because I had high fevers. And even a lot of teachers, I mean, my children didn't have school Friday because all the teachers were getting their vaccine on Friday.
Same with my children. Yeah.
Yeah. So I think that's a great point that Dr. File made, which is a good message to give to the community.
Yeah, I definitely would not get it the day before the wedding.
The other issue with that is there's no good data to say that somebody who has a stronger reaction to the second dose has a stronger immune response. But at least, you know, something to think about is if you do have that reaction, it doesn't mean your immune system is functioning, and you could take it as a good sign. But again, there's no direct correlation between that and level of antibody induced.
That's a good thing to add.
Yep, that's a great point. Yeah.
Okay, I think Alex, we have one more question, and
yep, our final question. So what are your recommendations for people that will be celebrating holidays? So that's among, I guess, say, you know, households that have been fully vaccinated, but that might have family and friends that have not been vaccinated. What would be like your cap on, say, coming up like Easter holidays or even going into the summer? Do you have any recommendations for people trying to start to prepare gatherings?
Well, until we have more guidance, I think we have to comply with the recommendations that are still available right now. And that is, you know, we have to wear masks and distance and all this. I know, and then we have to follow the local health department recommendations and ODH. I mean, as you know, actually last week, Governor DeWine did put forth some new criteria. For example, that you could have sporting events in stadiums outdoors with now 30% capacity, which is much greater than it was before. But that's because it's going to be outdoors, and all the spectators still have to wear masks, even if they've been vaccinated. They still have to wear masks, and all the seats have to be distance apart. So this is, you know, sort of a gradual opening. I think this is the way to appropriately do it. I know that many states are just completely opening everything, and I think this is a big risk, actually. But I think doing it in a graduated way is the best way for us to get out of this pandemic, because we will get out of this pandemic. And I think that the graph that Janaki showed is very telling, because I think it was by July, she said, if we combine natural immunity from infection and the vaccine that we're going to have reached this herd immunity. And that's when we're really going to be able to open up all of these and stop a lot, or at least, stop a lot of these processes of the masks all the time, et cetera. That's all what we're waiting for, but we can't do it too soon. We still have to practice and be vigilant, or else we run the risk of having another surge. And that's the concern of exactly what you mentioned, because of holidays coming up, and actually because of all of the quote spring breaks that are going to happen. There's a lot of concern about, traveling during spring breaks. Is that going to be a stimulus to a surge? I'm hoping not, because we did not see it with the New Year's Eve, and even with the Christmas we didn't. We certainly saw it with Thanksgiving, but we'll see.
Well, thank you all so much for being here. We truly appreciate the time that you've taken to prepare your presentations and share your insight with our community.
Thank you for having us.
Yeah, thank you.
Yeah, thank you so much. We really appreciate it.
Well, stay safe.
You as well.
Yes, thank you. You too.
Take care, everybody.
All right, thanks everyone for coming.
Thanks so much.
All right, Alex, I'll see you tomorrow.
Okay, sounds good.
Bye.